Hey guys, welcome to another episode of The Last Zebra. I'm your host, Dr. Ugo Ezema. I have with me today Dr. Matt Finn, cardiologist at Turbo General, where I work, and it's a great honor to have you here. Thank you so much for coming through.
Thanks for having me.
Of course,
great opportunity.
How you doing?
I'm doing great. Yeah.
So we met at Turbone, like I said, and you are a interventional cardiologist.
That's right.
How long have you been doing that?
So my training process took about 13 years from start to finish, and that's after undergrad. But I added a few things to that. I've been out for almost 5 years now. I would say 2.5 as an attending in New York at Columbia University in Manhattan, and then now a year and a half here. So maybe a little under 5 years.
Is that where you trained in New York?
I did. So I started, I grew up in Destrehan, Louisiana, kind of between Houma, where we work, and New Orleans, kind of halfway. I went to grammar school out there and then went to high school in the city here in New Orleans. Then went to University of Texas, LSU Med School after that, and then did residency at Hopkins in Baltimore.
Yeah.
I also did a chief resident year, which was one of the best years of my training. And then went to Columbia for my interventional training. I did general cardiology first. I also got a master's in public health, or a master's in statistics, really, from the School of Biostats there at Columbia. And after that, I did an interventional fellowship and a vascular fellowship.
You did both?
Yep.
Wow.
Yep. So it was a long road, 13 years, I think, in total of training. But as you've said many times on the podcast so far, it's about the journey, not about the destination. I wouldn't trade it,
That's awesome.
Wouldn't trade it.
You mentioned chief year was some of your favorite year, one of your favorite year. Why is that?
It was really special. Getting to work with the interns and the residents, in such a critical time in their development. It was just a really special situation. And Hopkins, the way they structure their residency, I'm a big fan of it. I believe they really put the interns and residents at the front line, making decisions, challenge them to be the face of the clinical team.
Right.
And so getting to be a part of that and just the institution that is Hopkins,
right,
was really special for me.
You've been at some pretty prestigious academic institutions. How do you go from that to non-academia, that's being the first thing, and then one in rural Louisiana, Houma?
So I would say that it sounds on paper like a really big change, going from Columbia and Manhattan to Houma, Louisiana, which is, moving into the rural part of Louisiana. And then we service some very rural places.
Yeah.
But the quality of care is incredibly high. And that's what drew me to come back home. I mean, I really missed home, missed my family. And then coming down to visit and seeing, the level of care that was offered at our hospital and in my current group at Cardiovascular Institute of the South, seeing the top-notch level of care, it became really exciting opportunity for me to come back and help the people of my community.
That's awesome. How have you always wanted to be a cardiologist?
So I was always drawn to the heart and the cardiovascular system from early on. Starting in undergrad, I had the pleasure of working at Ochsner as a volunteer, and I worked with my uncle, who was an anesthesiologist. I got to shadow him, and he he did the anesthesia for a lot of adult and pediatric heart surgeries. And I thought the anesthesia was fascinating, and I really thought the whole cardiovascular physiology was incredible. So I was just always drawn to the heart, learning about the heart, thinking about the heart, felt comfortable clinically dealing with cardiology patients. And then, I didn't know exactly how my career would unfold, but it just continued kind of down that path. and I developed a real passion for it. And so it became a clear choice for me when I was in residency that that's what I wanted to do. Also in residency, I found that I really enjoyed doing procedures.
Yeah.
And cardiology does offer, a way to be hands-on in patient care. So that was another attractive aspect to it.
Is your uncle the only doctor in the family?
Yeah, the only doctor in the immediate family. We have several PhDs in the family, but he is the only physician that I can think of off the top of my head.
Was there any other thing you entertained? Did you entertain anesthesia, for instance?
I did, of course. Yeah, getting to work with him was such an incredible experience. Also, as many cardiologists do, entertain pulmonary critical care. I mean, they run closely together. There's lots of things that interested me over the period of training, but and general internal medicine. I love being the chief resident and working on the hospitalist unit, basically. So, I would have been happy doing a lot of different fields, but cardiology has been a great field to go into, and I've absolutely loved it and love it day to day.
That's awesome. Academia, right? So again, going back to Hopkins, Columbia, and of course you mentioned the way you speak about the role of a chief resident has a hint of passion in there too. Would you ever go back into academia in a role that is for trainees or training trainees for future cardiologists?
So one beautiful thing about our group at Cardiovascular Institute of the South is I still look at it as academics.
Oh.
Some people call it private-demics because we are a private group, but we do a lot of work publishing, writing still.
Awesome.
We have a fellow that we train. Last year we trained 2 fellows in advanced vascular interventions.
Well, I didn't know that.
Yeah. So they don't come to Terrebonne particularly often, and they're not in the unit as much. But yeah, so that's a great opportunity to train at a very high level. I am hoping that we can work as a group to expand that training further because it's a real passion of mine.
Wow. Yeah, I didn't know we had, not we, but I didn't know CIS had fellows that come through. So that's a 2-year program.
It's a 1-year program, and it's added on after the interventional year. So you do a general cardiology fellowship, then you do a interventional coronary year, and then this is an optional additional year focusing on vascular interventions, both arterial and venous, that CIS offers.
How much, what's it? Because I always think of interventional cardiology as basically vascular. How much more different is the extra fellowship?
So I would say that's one real area of variability across the country. Cardiology, I think could be better on the larger scale at training people on vascular disease. There's a lot to learn in cardiology fellowship and a lot to learn in internal medicine fellowship. And vascular is so prevalent,
right?
And I feel like there's an under focus on it. So having that extra year for me, I felt was needed to be, adequate to treat these patients. I needed to focus if I wanted to make that my area of expertise.
Is there an anatomic or specific limitation to the vascular, geography, body geography that you engage in? I imagine the chest, of course, but.
So there's not, no. I know a lot of cardiologists will just stick primarily to the heart, interventional cardiologist. There's also, as the field has developed in recent years, interestingly, has interventional cardiology become a little bit stratified. So Columbia is a really nice example because they have several advanced fellowships that stratify things out nicely to specific areas of focus. That way, people get really, really skilled in their particular area. And you could argue whether or not that's the best way to do things. And there's programs that certainly have a more broader second interventional year. The first year is kind of broad, mainly coronary intervention focused. And then the second year at, for example, Columbia, where I train, the second year you can choose one of several pathways, one being structural heart, which is TAVR, mitral clips, Watchman procedures, PFOs. So those kind of structural heart procedures. The second would be vascular, which I chose, which at Columbia we ran the pulmonary embolism response team with a wide variety of teammates. I wouldn't say we ran it; we were a part of it.
Right.
So that collaboration was a wonderful thing to be a part of. And then we also focused on critical limb ischemia, wounds, DVTs, claudication, prevention of vascular disease, in addition to just doing coronary interventions. A third pathway that's available is complex coronary interventions, also known as CHIP, or complex high-risk indicated procedures. That involves doing advanced coronary work, a lot of times with the use of mechanical circulatory support for the heart, for example, the Impella device, which we see a lot, or a balloon pump device, and also in some circumstances doing chronic total occlusion procedures. So coronaries that have been blocked for a long period of time and opening them.
There are a lot of, I think in just the last 10 seconds, I just realized there's so much more subspecialization in cardiology, because I think I always thought of interventional cardiology and electrophysiology, and those are the two main, EP and interventional cardiology are the two main ones that come to my mind whenever I think about subspecialties and of course, heart failure, subspecialties in cardiology. When did that subspecialty, interventional and of course vascular, when were you aware that that's how deep you wanted to go into this?
Yeah, so that's a really interesting question. A lot of people within cardiology struggle which path to go down, because there's so many options. There's also, nuclear specialties such as stress testing, PET, imaging, combining echo, CT, MRI, and then heart failure, advanced heart failure, and EP. There's so many options, and being a general cardiologist, which includes all those options.
Right.
So trying to find your path within cardiology, it can be challenging, and a lot of people switch. I did switch. So I was initially planning on being an interventional cardiologist because I always enjoyed those procedures. I enjoyed the hands-on component of helping people. And my initial plan was to do structural heart. But as I moved through the years, I found a real passion for vascular disease. I love taking care of the patients, helping them both with their pulmonary embolism, with their vascular disease. Not to take anything away from structural heart, I think it's absolutely incredible.
Right.
But I also think it's very saturated at this moment with cardiologists, and I also think that vascular has gotten pushed to the wayside a little bit, and that cardiology is not focusing as much on a very, very important part of patient care. So I view it as a real passion of mine to promote vascular care, promote awareness of vascular care, and both teaching fellows and my patients about vascular health.
What are some of the specific challenges that you have faced with going from medical school, residency, fellowship, and then these subspecialties? What is, if you can think of like top 2 challenges, especially in that is worthwhile for anyone who's interested, that they should expect and maybe can learn from your experience, that would benefit them to know, hey, this is required. This is what's going to be required of you to go down this path. Well,
I mean, I think we share a lot of the same steps, challenges, with pulmonary and cardiology and internal medicine in general. It's mission oriented, so the patient I always try to put first. It's not about making money. It's not about, volumes. So, and a lot of times it's inconvenient, it involves working long hours, working holidays, and the cases can be hard. It can be hard on your body even. So I'm scrubbed into cases sometimes wearing lead to prevent myself from getting irradiated from the x-ray machine, which we use to do our procedures. So I would say it's just a grueling, hard field, but I do it because I want to help people. Same reason you went into medicine, and I feel like we do that day in day out, and it's one of the few. It's absolutely incredible what we do day in day out to help people.
I think one of my favorite things about, especially having seen your work, is, and you brought up pulmonary embolism, PEs, clots that travel to the lung, is how transformational in the span of 24 hours, how that patient can feel from the time when they start having this overbearing symptom of shortness of breath that is progressively worsening. And of course, you guys do thrombectomies, so taking that clot out. I'm curious to know, because from the time I was in residency to now, which is about 7 or 8 years, so much of the way we talk about care for clots, for instance, has changed. And you've been in practice now for 5 years or so. What has been, I imagine the field is constantly changing quite rapidly. What's been the biggest change since when you were done with training to now?
So I think it's been a total paradigm shift in pulmonary embolism. And I think it's a true success story in medicine because it's been so collaborative, across the subspecialties. It's really been a beautiful thing. Everybody working together. Yeah. The politics have largely stayed out of it. It's been really cool to watch. And it's just focused around making people feel better. And the research is now pouring in, showing positive effects of these procedures. And more to come soon with several randomized trials here in the next year expected to finish enrollment and probably publication in the next 2 years. So it's a really exciting time in pulmonary embolism. And the paradigm's changed from, only treating massive PEs or submassive that were transitioning to massive, meaning submassive, meaning, tachycardic, borderline low blood pressure, relative stability, but not totally stable, or a massive PE being highly unstable, low blood pressure, a very critical situation. Those are the only ones we were treating by pushing TPA. Now to having procedures that we feel very confident in our ability to help these people with a very, very low complication rate from the recent studies. Even in massive PE, the complication rates was extremely low in the recent thrombectomy studies. So it's a really exciting time in pulmonary embolism treatment, and it's something I've become really extremely passionate about.
Yeah, I think PEs always leave, especially when it happens the way it does happen, ever so suddenly, especially inpatient, because we rarely ever get to actually be at the beginning of the episode, right? But there always something. I can think of all of my patients who have had PEs inpatient because it's such a big deal, and how important it is to diagnose it early. And I know a lot of providers, emergency room docs, critical care docs for sure, who their experience with pulmonary emboli shifts the way they practice in such a way that they don't want to ever miss it again. And so to hear about how the progress about taking care of these patients is really, really cool to see. And I've definitely seen it firsthand with where we work. What sort of changes would you make now to how you have been trained? What's something that you wish could have been different about how you were trained? Granted, you've spoken very highly about your program.
Yeah, I had a wonderful experience. I mean, it was long. 13 years is probably too long, so condensing it maybe by a year or two. But I chose to do extra things. I chose to add the chief resident year, which I wouldn't trade for the world. I chose to do a master's in the School of Biostatistics, which I also wouldn't trade.
Oh, yeah.
So those 2 extra years, added time. But would I trade it? No. We could sit here and debate whether or not general cardiology needs to be 3 years, or an interventional or internal medicine needs to be 3 years. But at the time, it felt reasonable. When we were going through it. Certainly certainly you're growing so much during that period of time. You're going from graduating med school and having the doctor name, but not being able to really take care of patients to intern year. By the end of intern year, I felt completely transformed as a person and my ability to take care of people. And that was still just kind of scratching the surface. Even though I felt like I could take care of a sick person, I could get them through, their hospital course, but I had so much more growing to do.
Yeah, I think I've always thought of the practice of medicine, and not always, but I think as the more I practice, the more I'm appreciative of the fact that medicine, just the way it is taught, it's experience based. You have to see it.
Agreed.
You have to see it. And one of my previous attendings have told me that the only difference, the way he describes it, would be the way he told it to me was the only difference between him and myself was that he's been doing this for much longer. And the longer you do it, the more you see, the more you engage, the more you learn. Obviously, it becomes a very different practice and experience for you.
It's a huge part of it.
Yeah.
Huge part of it. And the other thing I would say is just, it is arduous, but it helps if you stay mission-based. You got to remember why you went into it. We went into it to help people, and people get lost sometimes in that process. Like, it's so arduous, so long. Sometimes you're away from your family and you lose that sense of mission. But if you can hold on to that, it really helps get through the training.
That's awesome. You did a master's, you mentioned, in biostatistics. I have now developed it's a newfound passion for biostatistics, and it comes from a place of one of the things I don't like hearing in common jargon is do your research, right? And whenever I hear that, I always think of my retort to that mentally, whether I say it or not, is most people, regardless of education, don't know how to do research and don't know how to interpret data and come to a well-informed conclusion. Do you feel that you need to do, if you were to hear someone say, do your research, knowing how you understand statistics, knowing how you understand data, reading a scientific journal, or reading any journal at all with any data output, do you feel that your experience with doing the masters puts you at a certain advantage for understanding that, certainly understanding what's going on and coming to your own conclusions as compared to like a layperson? In this case, a layperson being someone that's not initiated in the world of stats.
Oh, it certainly elevates the conversation.
Right.
Statistics is become so important. And in fact, it's driving this whole AI generation. All that is advanced statistics.
Yeah.
It's modeling based on, artificial intelligence and machine learning algorithms, which is, advanced statistical modeling.
Right.
So it's been pretty cool to be a little bit into that. I mean, I would say, as a practicing interventional cardiologist who's also trying to do research, it's hard to stay up on that. I mean, that would be a full-time job to stay up on machine learning. And I have some friends at Columbia who are able to do that, and it's so neat to watch them thrive and grow in that way. But it certainly elevates the conversation, and you read papers differently if you have the ability to dive into them. And that's one thing I love doing. I actually really enjoy reviewing papers, when I am asked to review, because, and I know people complain about that because, one, it's not compensated, it takes a lot of time, but that's part of the scientific process. So I do enjoy trying to lend my time to review when I can.
What are some key things that when you're reviewing a paper, if you were to give someone so if someone is listening to this and they're like, well, what are three important things when I'm reviewing a paper that I should take away from it?
Oof. Okay.
That's a tough one.
So yeah, no, it's not particularly tough. I mean, the first thing you got to distill down is what's the question being asked. So it's usually you're looking for, you have a treatment and you have a population, and then you're looking for an outcome. So you got to identify those three things. So that's the first thing you would do. And when I'm reviewing a paper, first thing I'm looking for is, are they clearly stating that? Or is it murky? You'd be surprised how often that question is murky.
Right.
Or even what kind of trial it is. Is it a randomized controlled trial? Is it observational cohort, prospective, retrospective? Meta-analysis. It's not always that well defined. So what kind of study is it? And what are the players? What's the outcome? So that's the first thing to look into. The next thing to look into is the validity of the trial. Is it internally valid? Meaning, are the methods they used, do they seem reasonable to you? And is it generalizable? That's external validity. So that's two major things. And then 3 is thinking about it, and this is more in external validity as well, but think about it in the broader terms of the study. Do you agree with their overall methods and conclusions? Putting it all together, do you agree with what they're saying, and how do you interpret it? How applicable is it? So that'd be three potential ways to look at it.
You mentioned artificial intelligence. How do you see that changing the way you practice down the line?
I think it really depends. This is a really out there question. I'm not sure I'm the right guy to answer this because I'm not so up on it. But it has potential to really add things to medicine in a really positive way.
Yeah.
And it can really potentially help us as physicians treat more patients effectively. I think it can really improve a lot of the day-to-day challenging work that we do, such as documentation.
Yeah.
It can really help with that. Ordering I think it has the ability to make our life a lot easier, and I think it also has the ability to improve accuracy. It's a question of how quickly to enact it. I think we need to have an extremely high standard before we're using it in clinical practice, because we can't have errors being introduced.
Right.
So if you get on ChatGPT, they're not really using it for clinical purposes right now because they're not ready. They're not ready to go there yet. I don't know where that stands. I think they probably have other fish to fry before they want to go there. But when I think of ways to use ChatGPT, it's always in a clinical sense, and it's always like, well, I'm not a doctor, consult a doctor. So that's what the answer kicks back to you. So right now, the obvious ways that AI can help us is very clear to me and clear to many people, but I think it has to be very carefully rolled out. So it's an extremely hard problem. And then comes the next question of how do we become obsolete in some ways?
Right.
Which is another interesting problem.
I'm a strong believer in clinical minimalism. So in the sense of making the way we practice a lot more efficient and elegant, right? So I think there are a lot of waste actions and products in the way we practice medicine. We tend to do kind of a bunch approach at the beginning, and then when we finally get the answer, if you were to dial back, you see that a lot of the things that we did didn't really help in getting to the answer and to the diagnosis. And of course, a lot of that is dictated by defensive medicine. So trying to cover your bases just for the sake of covering them, to avoid litigation and things like that. My hope is that artificial intelligence in medicine kind of helps alleviate, one, like you said, some of the scut work, right? So much of what we do is repetitive and redundant, writing notes, extensive notes for, whatever reason. Notes are necessary, of course, but sometimes we're not doing notes to serve our colleagues or to serve the patients in terms of delivering information. We're doing it to, meet requirements for insurance, to make sure that, the hospital and the work that we do is adequately compensated. So I'm looking forward to that version of artificial intelligence that kind of augments and adds.
Yeah, it's going to be.
Yeah, and
cool.
makes our work much more patient focused and removes those additional stressors that could make it a little bit overbearing.
And you can also think about from the research perspective.
Oh, yeah.
You know, one of the most painful things to try and do is build a database. So using natural language processing to build a database for you from the medical record, if it were to be allowed, could be a amazing potential opportunity.
I want to, because then you could, oh man, the time it'll take you to actually get to that data and then analyze and interpret that data.
And that's already here. Companies are doing that.
Yeah.
So
that would be awesome. Wow, there's probably going to be an exponential increase in changes in the way we practice if this gets implemented.
Yeah, I mean, I'd say that society tends to adopt these things somewhat slowly.
Yeah.
So I do think that there will be a gradual utilization of it. I don't think it's going to just take over the world all at once, or I hope not. But I think a gradual improvement and a shift would be interesting and cool to see.
On a day-to-day basis, what do you look forward to the most?
I think there's a clear answer there. It's my patient interactions. You know, that's why I went into medicine. I do love doing research, but the one-on-one individual patient interactions, helping the people of our community, is why I get out of bed. That's
awesome. Do you feel like there are situations where that patient to doctor interaction is a little bit more challenging than most, and how do you navigate those situations?
Yeah, that's always a tough question. There's certainly, times that are challenging, particularly in the ICU. You know, there's different family members coming in with different motives potentially, or different outlooks on life, and trying to understand everybody's point of view can be very challenging. I just try to keep open-minded and just try to be there as someone to help. I went back to, my mission is to help the patient, help the family. And I just try to stay focused on that. Much better than me from having tons and tons of family meetings in the ICU. The meetings can go different ways, but I just try to not always take a agenda to the meeting. I try to, just try to give the family the information, make this decision together the best we can.
Yeah.
In line with the patient's views.
Yeah, I think certainly the idea of or trying our best to not walk into these situations with preconceived notions, that's so challenging. It's so difficult sometimes, especially because before you walk into almost any room, either you've seen something or you're getting kind of secondhand information, reports from the nurses or whoever has watched an interaction, and you may walk in there with preconceived biases that may affect the way you present the information, and how you actually interact with those families. And I think that can be particularly challenging. So I agree. Trying to just clear my head before I walk in, and try to be as open, and to deliver the data. And every once in a while, I'm still struggling with this in practice so when a family asks for specific personal advice or specific personal recommendations, I still struggle with making those decisions. It happens almost every ICU week where I'm challenged to give advice on what would I do. I'm sure that has happened to you. How do you navigate that? Because I think that's that's such a personal and specific question, and it does put a certain weight of responsibility beyond what we're normally, because we have an understood weight and responsibility of being the provider and the caregiver, the physician for our patients. But when the family member or the patient asks you for your specific recommendation, what would you do if you were in my shoe?
Yeah, I find that comes up a lot. You get from the patient or the family, you're the doctor, make the decision. And I try to reframe that conversation a little bit. Yes, I am the doctor, But I'm here to present the data and try to make a decision together in line with what the patient wants for their health and give them the different options, lay it out, and make the decision together. I'm not really in the business of dictating care. And this comes up so often with procedures because there's real complications involved in procedures, and we have to go into detail and explain those. And sometimes people would just prefer to deal with the risks of not having the procedure. So I try to lay it out and make a decision together. Even when they push you to just try to make the decision for them, I try to avoid doing that and come to a consensus among the different options.
Yeah, procedure is such a great example of that, because a lot of times the way, and I've caught myself doing this too, the way we're kind of presenting procedures is it does come off as we need to do this, we have to do this, and not this is our option. And now I'm reflecting on how often do I actually give the option to do nothing, which should be a real option for all of our patients, I feel like. But I don't know how many times I could honestly say I've in earnest given that option to my patients.
Yeah, I mean, frequently it's not a good option to do nothing.
Right.
And I feel, as a proceduralist, a lot of times the family, in my experience, the family feels better, even if you have a bad outcome with the procedure. If it's an emergency situation or an urgent situation, the family feels better knowing that you tried.
Yeah.
And so I'll explain that part too. Like, we don't know how this is going to go. PE is a great example.
Yeah.
There's a lot of risk. These patients are very sick. Mm-hmm. We don't know how this is going to go. We do know that from the recent studies that the data shows the complication rates are low, but I can't tell you, but I do in most cases feel like, patients feel better knowing that we tried to make them feel better.
Yeah, absolutely. Absolutely. And I think being upfront about that, and especially, there's one thing I'm learning is to be very comfortable with two things over the last couple of years. Is being comfortable with not knowing why a patient got worse or why they got better. Sometimes you try, and, you use your skills and your training and your knowledge, but sometimes you just don't come to an answer. And I'm learning to be okay with that. And so I feel like really the way we've been trained, because training in academia, the way it's meant to be is for you to learn from these experiences. It's a why endeavor. And until I started practicing, those whys became less important, and focusing on the person, the who, then starts to take focus. And that's been my journey, especially since I've become an attending.
I think it takes a lot of patience on our part as physicians too. Sometimes you have to pull that out. You have to let things develop a little bit, let the family come around to the decision. And so often we go in with an agenda, so that's what comes back to that. I try to, one is not have an agenda, and two, be patient with the individual and allowing them to make their decisions. What
are some of the more, how much have you changed personally between training, and in my mind, when I think of training, I include medical school, residency, fellowship, and all the, multiple sub fellowships. But how much have you changed from that to who you are now since you've been working? In terms of the way you practice or the way you think about practice?
Well, I think you change immensely with experience. You just have experience to lean on. Mm-hmm. So it's hard to compare myself back to when, I was an intern and I wanted to hide underneath the table on my first day. I think just with time, you get a different outlook and a different perspective on your interaction with patients. I do think, residency gives you the unique opportunity to become kind of a mini expert in a lot of things as you go through, and you get really good at certain things when you're focused on them. And so I try to go back to that mindset of when I was a mini expert, when those situations come back, go back, do my research, think about the things I knew that helped me through those scenarios. think about the family meeting techniques that I developed during residency to, the lectures that we had on family meetings that helped me in those scenarios. So, there's certain things that I would say I'm better at now as a clinical cardiologist, interventional cardiologist, and there's certain things I would say that I was better at as a resident. Just depends on what you're doing, because these discussions are so challenging that it takes real expertise and data, and you have to practice. If you're not, that's why they call it the practice of medicine. But if you're not practicing it day in, day out, you do a lot more family meetings than me.
Right.
So, your skill in the family meetings probably better than most interventional cardiologists that are having them, but not at the same frequency as a intensivist. Right. So, or a palliative care doctor, for example. So leaning on the different subspecialties to help you in the scenarios is also important. And you learn to do that more also as you progress through training and through life.
Yeah. What would you hope for in the next few years? Like, there's a version of you 5 years. I like questions like this because it addresses hope. And if you look back, do you feel like the person you are today is who you thought you would be? So, and then looking forward, who is the person that you think today you will be in 5 years?
I think if I look back and saw where I am now, not to sound arrogant or anything, I would be very happy.
That's awesome.
I'm at home in Louisiana near my family. I've gotten to this point in my career. I'm sufficient in cardiology. I have a practice. I love treating my patients day to day. So I think I'd be very satisfied. As for where I'm going, I think continuing my goals that have gotten me to this point, continuing to challenge myself to be excellent procedurally, adopt new, and a lot of this is just the framework of our group at Cardiovascular Institute of the South and the mission statement that we have instituted by our founding doctor, Dr. Walker. It's quality of care first, respect for patients, technological superiority, so being capable with all the technology and doing research. So if I can focus on those things, and a particular passion for me is research. Right. And as you come into a new group, into a new area, I think that could be built up more down here. So that's something I'm really excited to help try to grow.
Research. What are you? Is there anything that you can tell us that you're currently working on that you're really excited about?
Well, at CIS through Dr. Walker and Dr. Fail and our structural heart team, there's a lot of clinical trials. And when I say that I think there could be more research done, I think just building on what they're doing. I mean, they're already doing incredible things. Right. So I don't want to take that the wrong way. I think that like within our own data systems, we could do more. But as far as a clinical trial standpoint, I think we're doing absolutely incredible research. So participating in that and continuing that is very exciting. But building up our own data research is something that I want to keep working. I think I lost your initial question a little bit, but
No. Yeah. So I guess I was asking if there within research, do you have a particular passion within research for interventional cardiology, vascular?
Yeah, vascular care.
Yeah.
There's so many great questions out there in vascular care and pulmonary embolism that still need to be fleshed out. That's one thing that did really pull me in to vascular is I felt like there's a lot more work to be done. And there's been a lot of progress in even medications, that we don't always talk about. Right. The PCSK9 inhibitors, the microRNA, interfering RNA molecules, the novel antiplatelets like low dose rivaroxaban. So these things have been progress. When, and if you'd asked me, 10 years ago, and you're like, Matt, is there a lot we can do with medicines? I would have been like, I don't think there's much more we can do with medicine. We got aspirin, we got Plavix, we got Brilinta, we got Prasugrel, we got all these different options, and we've made a lot of progress. We got statins, we're doing well with cholesterol, and then just all these new medicines that come out and iterate further, it changes your perspective a little bit.
cardiovascular disease is if I'm remembering this correctly, is the highest mortality of all the disease processes, right? So I like to now, I think preventative and primary prevention is also coming into the forefront, and us having a lot more focus on that. It's very challenging in South Louisiana to make a cultural shift where that is.
Yeah, I was hoping you would bring this up.
Yeah, to make a cultural shift where that is concerned. What are some ways that you're thinking? And of course, the easy ones are obviously diet, exercise, etc. What are some ways in terms of community outreach and that, you guys are doing that we can, probably get together to kind of switch how and take care of our patients from the very, very beginning and see if we can prevent some of these disease processes in the very first place?
So the easiest low-hanging fruit is smoking.
Yeah.
I mean, it's just so devastating in our region, the amount of smoking. And it's not like that in other places in the country. I mean, there are places it's endemic like it is here. But
Right.
For example, in New York, a far lower percentage of the population smoke than here. I remember my first day, I think I had 12 patients and nearly all of them smoked, and I was shocked.
Wow.
And a clinic day in New York, I would see a full day of patients and not have one smoke.
Wow.
So the difference was alarming to me. And, I think we have to do more. We have to do more work in that area. We have to do more outreach, more community programs, get in the schools, just things that people have been doing for years. I think we need to continue doing them. I think we have maybe lost a little bit of steam on some of these programs, or that maybe in our youth that we're focused on, because other problems have come up, that have taken us away from the very simple low-hanging fruit of smoking. The other big problem that's easy to discuss is obesity in our diet. I think we need to eat less, and I think we need to eat less meat, more vegetables, and less fried food. It's very simple, very, very simple. Eat less, eat more vegetables. Fruits too, but, green leafy vegetables.
Right. What do you think about the whole, because, there's every year there's a new fad diet, right? So keto, and then I think I just read about the carnivore diet recently. Speaking about diet changes and obviously eating less meat, what do you think about these fad diets that come up that on one hand kind of causes crash weight loss, but clearly these things have downstream effects?
Yeah, so I'm not a big fan of dieting. I think that lifestyle changes are the way to go. To just strive to live a healthy life. When I'm looking at a menu at a restaurant, and I'm definitely not perfect. My weight fluctuates. I would like to be, maybe 10 pounds less too. And I eat more meat than I want. Yeah. But, when I look at a menu, I'm trying to make a good decision every time I look at the menu. It's like, I'm going to get fish today, or I'm going to try to go meatless today. When I'm at a restaurant. When I'm at home, I have more control over that.
Right.
Same thing at the grocery. I try to make good decision. I don't buy high carb junk food. I try to spend more time in the fruits and vegetables aisle. And building on that is, I understand, especially when you have delicious, amazing food like we have here in Southern Louisiana,
Lord knows.
some of the best in the world, how hard this is. I'm not blaming anyone.
Right.
I understand how hard it is. And I also do think that these, the GLP-1 medication group is a nice adjunctive medication that can be used and will be used more and more to help people. And I've seen very positive effects so far, and the data is starting to come out. So I think it's going to be an important part of healthy lifestyle in the future. I'm hoping this trend with these medications continues, because all the data is looking very positive. I've seen, the recent New England Journal reports and such. So I think it's an exciting time in cardiovascular disease in that area.
Yeah. Speaking of New England Journal of Medicine, just going back to kind of research, do you guys do an active journal club with?
We do, yeah.
Oh,
Yeah. So we have two big meetings that we tend to do within our group. And, we should probably expand it. It would be wonderful to work with the internist and the pulmonologist, or really anybody who wants to get involved. So I think we need to work on expanding. We have a journal club, and then we also have a cath club that we do where we look at angiograms and discuss our cases. And, some of our senior physicians like Dr. Fail has been really instrumental in getting that started within our group. So it's pretty neat.
It really is cool to have that kind of a mentorship. That's something that I've always appreciated, especially about you guys' setup, and we have the same with ours. We have some great leaders in our group, Dr. Lorio and Dr. Bourgeois being the head, the guys that kind of set the pace for us. I would love to have a journal club. I think kind of keeping that, because that's a vestige of medical training that I think most places kind of just drop off after they start practicing, especially in private practice. I think that's really awesome that you guys do it. How often do y'all do it?
We've been doing it quarterly.
Okay.
Quarterly, and we started just doing it at our clinic, and and then kind of making it informal. But I think we're trying to start doing it at restaurants and stuff. Yeah, make it more of an event. So we'll have to maybe we do a separate one together, like a more general one, that we can learn from each other.
Yeah, that'd be awesome.
And we could work on doing that together. It'd be really cool.
Yeah, I'd like that. I think that'd be really, really cool. And it kind of forces you to stay up to date. And that's important. It's evidence-based medicine is what medicine is supposed to be about.
And it also builds relationships, which I think is just as important as anything else. Being able to pick the phone up and call Hugo and say, well, this is what I'm thinking with this guy. What do you think? Are you okay with this route?
Right.
Being able to have those one-on-one conversations really enhance between the doctors, really enhance patient care.
Absolutely.
And if you don't know each other, it's hard. That obstacle of just developing the relationships is, especially coming in, as a new person, trying to develop those relationships is a real challenge, and something like this could help.
Pulmonary and cardiology, where shortness of breath is concerned, we always go back and forth on what's causing it.
It's definitely the lungs.
It's definitely the heart. So, but I find that our relationship where we work, it's not contentious the way it is. I imagine most places, certainly some places where I've trained, it's a different kind of relationship with pulmonary and cardiology, because a lot of our symptoms overlap, if not 95% of our symptoms overlap, and we function in the realm of, well, I've done my PFTs. It's not the lungs, and of course you guys come with your we've done the cath. It's not the heart, but it's really cool how I think we have a really good collaborative effort where it comes to taking care of our patients, and definitely having that camaraderie absolutely helps and makes that entire process much more seamless, much more elegant, and much more efficient. Like I was saying about the way I like to practice, at least the way I like to think about my medical practice.
Yeah, and it's interesting. That's the opposite of AI.
Yes.
It's picking up the phone and calling a person, or as we're meeting today, face to face. So I think we need to, it gets tempting to lose that in the modern, epic environment where I can just get on Haiku and message someone. Picking up the phone or making the face-to-face contact, I think really there's something about it that's special, and we can't lose that in the coming generations. And I feel like it's these kind of interactions are getting further away.
Right.
So I think the face-to-face, you need to make the extra effort.
It's important.
It really benefits patients if you do.
What's your non-medical hobby? What's your thing?
I have a lot of hobbies. Recently, it's been athletic endeavors. So I just ran the New York City Marathon.
Whoa.
Yeah, it didn't go so well. It was pretty painful.
You finished it?
I finished it.
Okay.
Yeah, I finished it. I was kind of limping to the finish, and I had to fly back and work. So I flew back that night, and that plane flight was misery. I couldn't, the flight attendants were making fun of me trying to walk to the bathroom because I couldn't bend my knees. But that was one of the coolest experiences of my life. if you ever have the opportunity, I highly recommend it. The New York City Marathon was just a really special, special thing.
It's a true marathon, and it's how many miles? It's
26
miles, right? I just saw not just, but over the past few weeks, probably a couple months, I saw an infographic about the pathway for the New York City Marathon.
Yeah.
And watching that like line course through the city of New York made it feel longer than, if you've ever been to New York, a few blocks can feel, oh my goodness, can feel like forever. But watching that little red line course through the city as it was showing you how long this marathon was, going across the bridge, and it's like, oh man, they call this a marathon. This feels like more than a marathon.
Yeah, I tell you, running, it felt like more of a marathon too. The bridges were tough, and being down here where it's pretty flat, I didn't really have the opportunity to train very well. There's that bridge right outside the hospital. I never ran that thing. All I had to do was go outside and just run up and down it before or after work, and I didn't do it, and I paid the price.
That was your missed
I blew
opportunity.
up on mile 18, which is where everybody blows up, and there's a lot of pain on a lot of people's faces who undertrain. So I wasn't alone. At least we were in it together, struggling. But it was a beautiful event, and I even broke into tears a couple times. How the support from the city,
awesome.
Everyone coming out. At one point in Brooklyn, there was a full gospel choir on the front church of the steps. I mean, that made me tear up. It was just incredible, the support for that event from the community.
When you say blow up, what do you mean on mile 18?
Like, you basically, I didn't have any more like glucose to make my legs move. And it was more, that's what you typically say when you're blowing up. This was more musculoskeletal. Like, my IT band was just killing me, and every step felt like somebody had a knife and was just like jabbing it into my kneecap. And I was like, oh my God, I have so many miles left. I have 8 miles left.
Did you ever stop, or you
I walked some, yeah.
Okay,
I walked some.
Okay.
Yeah, which was, my goal was to not walk. So, but at least I finished.
Yeah, I think finishing is heck of a... Have you ever run a marathon before?
This is my second.
Okay.
I ran Philly, which is also amazing marathon, an amazing experience. And I did much better in that one. But that was also when I was younger.
Yeah.
And then my other pursuit is triathlon. So I got into triathlon. I don't know if you know Murray Morella, our nurse practitioner.
Yeah,
so he kind of got me into it.
He does it?
Him and my spouse, we do them together. So, so he's done, I think, 3 Ironman, full Ironman. So he got me to do a half Ironman, and we did that. We did Galveston in April of last year, and that was really cool.
So the triathlon in this case is swimming, running, and...
It's swimming, biking, and then running. So kind of from most dangerous to least dangerous, and how you can hurt yourself over the course of the race. Because by the end, it's better to be on your 2 feet than like in the water.
Yeah. How long is each component?
I hope I don't screw this up, but so I did a 70.3, which is a half Ironman.
Okay.
So it was a 1.25 mile swim, I think a 56-mile bike, and a half marathon, which is 13 point something. I
have no words. I play soccer for an hour.
Well, soccer's
on Wednesday night.
Soccer's damn hard. So I'm sure you could do it. It's just a matter of training. Yeah. And Murray helped me a lot. He was not kind of my coach. He was my coach.
Yeah. What's training for that like? So like, if you're swimming for 1.5 miles, are you going to the YMCA?
Yeah.
Yeah,
so I go to the YMCA in Homa. It's a great place to swim.
Yeah.
Beautiful pool. And just grind out some
laps.
Yeah, grind out some laps. Do some flip turns.
Were you ever able to finish a full practice? A full like length thing in practice? Like
no, so usually you don't try to do a full practice. There are sessions that are called brick sessions, which are where you pair like a bike and a run.
Okay.
Or a swim and a bike together to get you the feel of transitioning. Because one of the hardest things is going from the bike to running. It's a brutal experience, and you can really train your body to overcome that a little bit. So doing the combined workouts helps prepare you for the event.
Nice.
And I'm highly mediocre. I just want to like, people ask me like, what event are you best at? I'm like, none of them, zero of them. I was just trying to get to the finish line and enjoy myself.
Were you a swimmer prior to doing this?
No, I was not a swimmer. And that's the barrier to entry for most people. And, you know, my spouse is an amazing swimmer, and, you know, we couldn't figure out why I couldn't swim. My family was really worried I was going to, you know, like drown in the first one. First of all, there's a lot of safety
nets.
You know, there's people out there, but if you're not comfortable swimming, it's probably not a great idea to do a triathlon, because you're out there, you know, and you have wetsuits which help, but you know, I was able to get better at swimming. We figured out that I wasn't breathing correctly. It was kind of hilarious. When I would take a stroke, freestyle stroke, I'd breathe in and breathe out of the water instead of exhaling underwater.
Oh, I didn't know that either.
Yeah, so you're supposed to exhale most of the time underwater and then turn your head and breathe in.
Oh.
And I was breathing in and out, so I was basically suffocating myself when I was trying to swim. And we're like, why can I only swim like, you know, 200 yards? And I feel totally exhausted now. Are
you exhaling through your nose or mouth?
I don't know. There's probably a correct way to do it, but I try to do both.
Because I imagine I would be so clumsy. At some point, I'd probably try to inhale while my head is face down in the water.
Yeah, I mean, I think some of it's a little bit natural once you get the feel for it. They say blow bubbles. So I read it in a book, actually. It was blow bubbles, and then I started like literally practicing breathing, blowing bubbles underwater, and it helped me get over it. And then I was like, I can actually do this all day, and I have zero concern that I'm going to drown. Now, I'm not going fast. I'm super slow.
Right.
But like, I could do it all day.
That's awesome. Any non-physical hobbies?
I like to read a lot, just for fun. I also like to listen to audiobooks and podcasts. So
you're going to listen to this one?
Yeah. Well, I don't know that I love to hear myself talk, so maybe not, but I'll definitely listen to all the other ones.
Yeah.
And I already have.
Nice. Thank you. What's the last great book you've read?
Oof.
That you'd recommend? And it could be, let's say, last great nonfiction and last great fiction, if you read fiction.
Yeah, I read both. I like Going Infinite a lot by Michael Lewis, about Sam Bankman-Fried. Oh. It's been very controversial because people feel like he took he took it too easy on him. So that's a decent takeaway. I'll let you decide.
Especially given everything that happened with him now, because he's still in trial, if I'm not mistaken.
Yeah, so he's been convicted, but they haven't sentenced him yet. That's my understanding. It does change your perspective on him, but I think reading it in the light of understanding the controversy is interesting too. Yeah. But it was a very, very fascinating book, and it actually made me understand the whole, Bitcoin, blockchain currency a little bit better.
I still don't understand this.
Well, I think most people don't.
Yeah.
But it did help. I think the explanations were good.
It is surprising to me how much people were enamored. Is that the word? Enamored by him? Because I felt like in the span of 1 year, that's all everyone was talking about. Sam Bankman-Fried and FTX. There's a whole arena. I think Miami Heat arena was named FTX Arena, and it's like, where's this thing coming from? It was all the ads were up, and come to find out this was what really was going on behind the scenes. I think I'm gonna have to go pick it up and add it to my collection here. How about fiction?
I was thinking about that. I've been mainly listening to nonfiction lately, so I wouldn't say that I've had anything really strike me in the fiction realm, which usually I'm more fiction oriented.
Yeah.
So I can't think of anything off the top of my head that's really struck me recently.
I don't know if any. There's always the classics, but I don't know if I myself have had any fiction either that I've read recently. Most of them have been exactly what we were just talking about, like books that someone wrote about. Like the biographies have been very fascinating to me. The last really good one that I read, and it was an audiobook, Trevor Noah.
Oh, I'm obsessed with that. I see it on your wall over there.
Born or Crying.
I saw it walking in.
Oh my goodness.
What a spectacular book.
What
So
a book.
moving.
What a book.
I'm with you.
What a book.
Highly recommend it.
Yeah. Have you listened to the audiobook as well?
Yeah. Hearing him read it is pretty special.
It's quite the experience. He's quite an individual. He also has a new podcast that came out. I haven't listened to it yet. I think it's What Now is what it is. And I also saw him this year when he came to visit New Orleans.
Really?
Yeah, he's so funny.
Oh,
he's so funny.
True talent.
I love that he can be funny without being egregious about it, right? So it's very. I think it takes a special talent to be funny and talk this way. You can either be funny and loud, or funny and quiet. And I prefer the funny and quiet kind of comedian. And he does such an excellent job, especially navigating so many complex topics without ever passing judgment. I don't know, just listen to him talk. It gives you the insight that he's given a lot of thought into a lot of stuff that he talks about.
Yeah, the book was so moving, what he's been through and everything. It really touched me.
Yeah. I like Trevor Noah a lot. Big fan. Well, thank you so much, man. This has been really fun. Cool. Yeah, we should do this again.
Anytime.
Yeah, I'll hit you up, and I'm curious to see what we catch up on.
We got to get working on that journal club.
I'm down.
Multidisciplinary journal club.
I love that. I think that would be awesome. Like I said, so much of what we do overlaps, so we should definitely do that.
Yeah, be great.
Yeah, man.
Thank you.
All right, man. Thank you.
All right.
Yeah. Hey guys, thank you for watching this episode of The Last Zebra. We have new episodes everywhere you listen to your podcast on Monday mornings, and videos of the podcast are available on YouTube on Tuesday mornings. Please like, subscribe, comment, and engage with our active listeners. Thank you, and looking forward to seeing you on the next one.